and discussion. Dr. Kalai, are you ready?
Yes, sir.
Yeah. Just a brief about the program, Dr. Preeta and Dr. Vishnu Prasad and Harishwar. Basically, it is basically the program organized by Association of Physicians of India, Tamil Nadu chapter, and it is coming under the Indian College of Physicians (ICP), and it has been organized to start with 5 years back. That is during the time of COVID. We thought of having some sort of platform, virtual platform for the benefit of the postgraduates. They were really lacking the clinical knowledge or clinical medicine. That's what the starting of this program by our now the current National Vice President Dr. Palniappan sir. And it is continuing as an ongoing program now till date. And it's just brief about this program. And basically, it's meant for only medicine postgraduates. What we are having, the current members in the group is going to be only short group. So only the remaining people would have joined as a live virtual program. So on live stream will be going on. So people will be joining during that. This one only the this group is very small group, but even then the remaining people will be joining as a live stream. There's a basic brief about this. And let me start the program and introduce both of you and the presenter and Harishwar also. By the way, Harishwar is our senior resident in the Department of Medicine. He is also interested in the teaching program. So it's really thank you to Harishwar for joining us.
Thank you, sir. Thank you for giving me this opportunity, sir.
Yeah. And to educate the postgraduates related to neurology.
Okay.
So I'm expecting these three faculties can be just brief about this. The way of the flow of discussion would be the PG is going to present the history, followed by the examination summary, and each and every stage of your presentation of the postgraduate, you can just try to intervene and try to discuss about historical aspect, differentials of symptom or the group of symptoms or syndromic approach, some whatever way you want to discuss. It is basically the discussion should be such a way that the postgraduates of MD degree going to be benefit out of this neurology case discussion. That's a basic idea. Since both of you joining first time, I just thought of a couple of minutes to brief you about the flow of presentation.
Okay.
And to advanced level of investigations may not be that much useful for this postgraduate MD. Basically clinical part and to some extent definitely investigations, to some extent therapeutics part also. I think they're going to be a bit familiar with this approach toward the individual symptoms and signs and proper elicitation of the signs, the techniques or the steps. It's more useful for the MD postgraduates. So it's slightly different way of looking at the teaching program. And with this, really thank both the senior consultants, Dr. Preeta, from Pishanti Hospital, Chennai, and Dr. Vishnu Prasad is also a consultant neurologist from Dindigul. Am I correct, Dr. Vishnu Prasad? You don't Dindigul.
Yes, sir. Yes, you're right, sir.
Yeah. Thank you.
Yeah.
And
Thanks.
we have with us senior resident from the Department of Medicine, PSG IMSR, Dr. Harishwar. Really thank you, Dr. Harishwar, for joining us today.
Thank you, sir.
And
Thank you.
we have with us Dr. Kalai is going to be presenting this postgraduate program case. This is going to be on neurology. Is going to present how to approach a patient with quadriplegia. Again, just over to the faculties and the postgraduates to take over the further proceedings of the session. Thank you.
Thank you, sir.
Thank you, sir. Thank you.
Good evening to one and all present here. I'm Kalai, third year medicine, general medicine graduate. I'm going to present a case on quadriparesis. Moving to the case presentation. A 55-year-old male, Mr. X, right-handed person, previously driver by occupation, resides in Coimbatore in a nursing home. Education status has studied up to 4th standard, and the history was obtained from the patient, and reliability is fair.
Yes, Kalai. Can you tell me the importance of knowing the residence in a case of, especially a spinal cord case? How is it correlated? Any correlation is there?
So if the patient is present in a crowded area who had previously, we can suspect infections. Or if the patient is coming from drought states, we can suspect any bacterialism.
Okay, so mainly it is fluorosis. Fluorosis is common in some parts of Tamil Nadu, especially Madurai and Virudhunagar side, and also Dharmapuri. And currently, even in Salem and Erode are coming under high fluoride states in the water. Okay, so fluorosis will affect the card.
Okay, sir.
Okay, proceed.
Okay, sir. Thank you. Due to the chief complaints, patient came with chief complaints of weakness and stiffness of all four limbs since 7 months following a trauma, and complaints of increase in frequency of urination for 6 months, history of burning sensation over back and lower abdomen on and off for the past 6 months, and complaints of cough with fever for the past 3 days. Moving to history of presenting illness, patient was apparently normal 7 months back, following which patient had a history of slip and fall forward at home following consumption of alcohol, the exact details of which he was not able to recollect. Following which patient noticed weakness of all four limbs, which was sudden in onset, non-progressive, associated with stiffening of all four limbs. Following which he was found lying down by neighbors who had taken him through a car and there were no neck braces were used while shifting. Patient recalled no event of change of cloths before shifting. And the trauma was not associated with loss of consciousness, abnormal movements, and he denies any ENT bleed. Following which the patient was admitted in the GH. Then the patient was catheterized and had drained a large volume of urine and was kept in intensive care for 3 days. And he did not recollect any usage of large mask or oxygen support. Then the patient was then initiated on physiotherapy and was transferred to ward, where the patient continued to receive regular physiotherapy and had noticed flickering of movements in both upper and lower limb. And patient was told that he needs regular physiotherapy and was discharged after 15 days of hospital stay.
So, Kalai, do you think that this trauma would have caused this sudden onset weakness?
Sir, by the history, it's only a trivial trauma, sir. So
Okay.
this trivial trauma can cause it if there is any underlying degenerative disease, considering his age. But there was no previous history of any weakness or tingling numbness sensations.
Okay. So, have you heard about the concept of red herring in neurology? Red herring. So, sometimes the underlying problem would have been different. So, it would have been precipitated by the trauma, and we would attribute it to trauma, but the problem would have been some other thing. So, that distraction is usually called as red herring.
Okay, sir.
Okay. And regarding alcohol, what are the effects of alcohol on central nervous system?
Sir, it can cause drowsiness, sir.
Okay.
Chronic consumption can cause cerebellar degeneration, sir. It can lead to ataxia, sir.
Okay. Can alcohol cause demyelination? Okay. Go and study about which part of the brain is particularly demyelinated by alcohol. Okay. And one more thing is alcohol patients, they are more prone for central pontine myelolysis when you correct hyponatremia rapidly. That can also present as quadriparesis.
Okay, sir.
Okay, proceed.
Patient was initially catheterized. Patient was initially catheterized and soon after the onset of weakness was discharged on diaper. At the nursing home, patient continued to receive on and off physiotherapy, which was he didn't receive properly, and he then started noticing gradual improvement in the weakness, both in upper and lower limbs. For the initial 2 months, the improvements were in the form of he was able to lift arms and legs, was able to sit with support, and was able to walk with support. Patient initially needed 2 to 3 persons for carrying out his activities of daily living. Now he needs 1 person for giving feeds, for changing clothes, and for mobilizing. Over the last 2 months, patient finds difficult to extend the leg and hold the objects, and also notice legs not to lie flat in the bed, and also notice deformities of the fingers. Patient also noticed increased stiffening of limbs while doing activities. Patient at present functionally can sit with support, needs initial help either from a person or a grip to climb, to change from supine to sitting posture, and can walk up to 200 meters with the help of crutches, but needs assistance for eating, bathing, changing clothes. Patient was not able to climb stairs due to stiffness. patient present, he came to our OPD with complaints of fever for 3 days, which was intermittent low-grade fever, associated with generalized myalgia, nose block, and running nose. Had cough with scanty whitish sputum for 2 days. She was not associated with postural diurnal variation. Was not associated with breathlessness or aggravation on having oral feeds. Hence, he was admitted for further management. There was no history of dysuria, loose stools, abdominal pain, nausea, vomiting.
So what is the most common site of aspiration?
Sir, right lower lobe, sir.
Okay. So suppose if there was fever with onset of sudden onset weakness of all four limbs, what will you suspect? If there is fever during the onset of weakness, what will you suspect?
Sir, we can suspect post that it could be transverse myelitis, sir, or it could be GBS, post infection GBS. Can be a
GBS,
possibility.
presence of fever during onset of weakness rules out GBS.
Okay.
Okay. Any other thing with fever? Yes, acute transverse myelitis. Then,
Sir, in case of if the patient had a loss of consciousness and had fever, we can think pontine hemorrhage presenting with quadriplegia.
okay, relating to spinal cord.
Cool.
So if you are having fever with a spinal cord type of weakness, you should suspect epidural abscess.
Okay, sir.
Okay. What is the most common organism causing epidural abscess? Okay. Okay. You go and refer. Continue.
Patient had a history of difficulty in combing hair, lifting hand above head, history of difficulty in mixing food, buttoning shirt, history of difficulty in standing and climbing stairs. Patient also had history of difficulty in insinuating, holding, and removal of slippers. Patient had history of inability to turn from side to side. There was no history of difficulty in lifting head above head. Patient had history of inability to perceive hot and cold initially below the neck region. The patient was also not able to feel coldness of the surface, cloth, insect bite for the initial 1 week following the trauma, then started noticing burning sensation over the back and hip, and there were no relieving factors. He also had a feeling of warmness of extremities and body initially, then gradually noticed to be improved. Patient did not have band-like sensation, nocturnal pain or awakening, or previous history of neck pain or change in head posture. No
So what
history
do
of
you
shock.
suspect if there is a nocturnal awakening because of the back pain
Sir,
if the patient awakes
there
from
is a nocturnal awakening, we can suspect any metastasis or osteomyelitis, sir. That
Yes,
could
good
have,
metastasis. Okay, what do you call that sign as?
sir,
It's called EC chair sign. So they will be
okay,
in
sir.
a state of flexion. If they extend their spine, the pain will
Okay, sir.
increase. So they will be in a state of flexion. The trunk will be flexed, like sitting in an EC chair. So it's called EC chair sign. So being an
Okay, sir.
elderly patient, that history should be asked. Okay, so what is the most common site of metastasis in the spine?
Sir, it is usually in the thorax.
Yes, good thorax. What are the malignancies can metastasis to thorax?
Sir,
Thoracic vertebra.
prostate, then lung, sir. And,
See, lungs and
yes,
breast is okay.
good.
So your CA ovary and CA prostate, they will metastasis to lumbosacral vertebra because through the Batson's plexus of veins. So it is usually the thoracic, but in some scenarios it can be
True,
lumbosacral
sir.
as well.
Yes. Okay, sir.
Okay. What about radicular pain? Will it be more severe in night or during the daytime?
Sir, it will be throughout, sir. He can't initiate the sleep only, sir.
Mm-hmm.
They will tell that history, sir.
So usually that is also worse during night because in the morning time, the paraspinal spasm will usually relieve some tension.
Okay, sir.
So when the patient lies down flat and at night, this radicular pain will be aggravated.
Okay, sir.
Okay.
Yes.
Proceed.
Patient had no history of shock-like sensation on bending forward.
Sorry, can I ask you one question? The types
Yes,
of,
ma'am.
the types of pain in neurology. Can you
Yes,
tell
ma'am.
me the types of pain?
Ma'am, there is a funicular pain, ma'am. It is a diffuse pain, ma'am, dull aching pain, or that would be paresthesias, ma'am. It is positive. It is a positive phenomenon due to heightened perception or reduced threshold, ma'am. and there could be numbness because of it is a negative symptom, ma'am. And
Okay.
there
Funicular
could
pain,
be,
where will you see a doctor?
when the posterior column is involved, we can have paresthesias and
Okay.
then tingling numbness, ma'am. And in case of cord lesions, we'll have funicular
Yeah.
pain.
Mostly
And there is,
intramedullary cord, no, you have the funicular pain. It
yes,
is a dull aching, non-localized. It is a non-localizing pain. You cannot,
okay,
with the
ma'am.
funicular pain, you cannot localize where the spinal lesion is.
Okay, ma'am.
It is not like radicular pain. So
Okay,
radicular pain, what will be the most
It will,
important thing you usually see in radicular pain?
ma'am, it will be
Two
a sharp,
points.
lancinating pain, ma'am, and it
Okay.
usually aggravates some coughing or
Okay.
dying.
It's mostly dermatomal pattern. Okay.
Yes,
In the dermatomal pattern, you'll have the pain. Okay, aggravated by cough, exertion, Valsalva. Okay.
yes. Then,
And then, as you told, it is more like in the night you'll have the pain.
yes,
Okay. And what is the other pain?
ma'am,
Vertebral pain.
yes, vertebral pain.
Vertebral pain. That is also which comes from the vertebral, like from the body, spinous process, and all those the ligaments. So
Okay,
that is a proper localizing pain actually.
okay,
Okay, of the spine.
yes,
So where will you get the vertebral pain? As you told, tuberculosis and like extramedullary
extramedullary,
causes. All the extramedullary causes you'll have the vertebral. All the intramedullary will have the funicular pain. Okay, that is the
Yes.
differentiating 2 points for the pain.
Yes,
So you're telling in this one, no, you have burning sensation.
yes, ma'am.
So burning sensation is a large fiber or a small fiber?
Actually, according to the gate control theory, posterior
No,
column, if
just
it is
want to tell
intact,
me. So whether local, we're just trying to localize. No, burning pain is small fiber neuropathy or a large fiber neuropathy?
it's due to injury in the posterior column. There will be increased sensation perceived as pain, ma'am. So it can occur both ways, ma'am. Either because of posterior column issue, or it could be spinothalamic burning
Okay,
sensation.
burning pain is more paresthesia. Burning pain is more of small fiber neuropathy. We always
Okay.
we will not localize to a large fiber.
Okay.
Yeah. Okay. Remember that.
Yes.
So in a spine, you're presenting a spine case. With that, you're having a burning sensation. No.
Yes, ma'am.
So it shows some small fibers also is involved in this patient.
Okay.
If he's a diabetic, then that will fit into it.
Okay, ma'am.
Okay.
Yes.
Okay.
Can we attribute this as funicular pain, ma'am, because it's diffuse over abdomen, thorax? Can we take it as funicular pain?
Yeah, we can take it. Yeah, we can take like that. Yeah, you're right.
Okay.
We can take like
okay. Yes.
Can proceed.
Yes. There was no history of radiating pain from shoulders to fingers. No history of pins and needle sensation. The patient is now able to feel hot and cold over upper extremities. There were no history of difficulty in walking a narrow path. The patient denies walking in dark environment post fall. There was no history of diurnal variation of weakness.
So, Kalai, what will you suspect if you have diurnal variation of weakness?
Sir, that could be neuromuscular junction.
Elderly male diurnal variation of, yes, myasthenia, or what is LEMS? Lambert-Eaton myasthenic syndrome. How will you differentiate both?
Sir, post work there will be a post exertion, there will be a
No, clinically you have only two differential points. So which will have preserved reflexes, which will have absent reflexes?
So myasthenia will have preserved.
Yes, good. LEMS will have absent reflexes. And one more important differentiating feature between the two is presence of autonomic symptoms in Lambert-Eaton myasthenic syndrome. Myasthenia will not have autonomic symptoms.
Okay, sir.
Okay, proceed.
Yes. There was no history of loss of smell or altered smell sensation, no history of disturbance of vision, no history of diplopia, difficulty in eye movements, no history of sensory loss over face or chewing, no history of loss of taste.
So if you're having sensory loss over face, especially being a quadriparesis case? What will you suspect?
Sir, if there is a anaclave pattern, we can suspect high cervical.
Yes, good. High cervical cord lesion. Okay. Okay.
If
Okay.
there is any perioral numbness,
Hmm.
it could be a brainstem.
Okay. Okay. Proceed.
No history of loss of taste, salivation, and deviation of angle of mouth, drooling of saliva. No history of hearing loss, vertigo, tinnitus. No history of nasal regurgitation, nasal twang, dysphagia, hoarseness of voice. No history of any dysarthrias. No history of loss of consciousness, seizures. Patient then noticed increased frequency of
If you had seizures with weakness, altered sensorium, what will you suspect? Especially post-infection or vaccination.
Sir, there could be any encephalitis.
Yes, what do you call it as? What is ADAM?
Sir, acute demyelinating encephalomyelitis.
Acute disseminated encephalomyelitis. So you'll have encephalitis plus spinal cord involvement, myelitis. Follows which infection usually? ADAM? Usually follows measles infection. Okay, proceed.
Patient noticed increased frequency of micturition up to 12 to 14 times a day. There was history of passing urine in clots before reaching restroom. No history of inability to stop the flow of urine while passing urine. No history of post-viral dribbling or burning micturition. There was no history of hesitancy or poor stream of urine. There was involuntary passage of stools present. There was no previous history of impacted stools or incomplete bowel evacuation. History of COVID vaccination, 2 doses were done. No history
So
of
from
dog
this
bite.
urinary symptoms history, which type of bladder you are suspecting?
So I'm suspecting and bladder, sir. Because,
why do you say it's and bladder?
So because he first thing he couldn't control his urge, sir. Then in between he couldn't stop the flow of urine, sir.
Okay.
So
what is it? True,
and
sir?
then-
Can you tell me the difference? Like, how will you tell it is a lemon or human bladder?
in element bladder, there will be a large bladder one. There will be dribbling.
No. Element human, element bladder, whether it is areflexic bladder, no, there is no reflex. The flaccid bladder. So what will happen? Urine will keep on collecting.
Overflow.
There will be overflow.
There will be overflow in continence.
So that history, did you ask him? Previously history that was there?
Previously, there was during this admission, they have catheterized and they have drained a large volume of urine.
Okay. Then it must be okay. Then what is
might be in spinal shock.
Symptoms for it might be in spinal shock. Symptoms for human bladder?
There will be increased frequency, ma'am. Then urgency, the urge incontinence, ma'am, that he couldn't control before going to.
So it is a hyperreflexive bladder.
Yes, he couldn't
dysynergia
stop
will be
in
there.
between the flow. Yes,
so dysynergia will be there. There will be incomplete voiding of the urine. There will be post-viral residual urine will be there. Yeah,
yes,
that is, these two are the most important differentiating factors. Okay.
Okay.
So where are you going to put it? Whether it's human or element?
I'd like to put it in human.
Human. Okay. You can proceed.
Yes. No history of dog bite, joint swelling, joint pains in the past.
Why did you ask for joint swelling, right? Any history of joint swelling?
So in case of any rheumatoid arthritis.
Okay, which part of spine is affected in rheumatoid arthritis?
So that would be subluxation of
Whether it is cervical, thoracic, I'm asking like that. Which part of cervical? Yes, good. So following COVID vaccination, if you have developed this type of weakness, what are the things you will suspect?
Post-vaccine related.
Yes, what are those complications post-vaccine related? Can you develop GBS after post-COVID vaccine?
Yes.
Okay, especially after adenovirus vector-based vaccines. Then what is VIT? VITT. So VIT is vaccine-induced thrombotic thrombocytopenia. So you will have a tendency towards thrombosis. And if there is involvement of anterior spinal artery thrombus, then they can develop anterior spinal artery syndrome as well. Okay, proceed.
Yes, thanks. There was no history of increased sweating, palpitations, orthopnea, PND. No history of generalized lymphadenopathy, weight loss, fever, night sweats, or evening rising temperature. There were no history of headache, projectile vomiting, blurring of vision, or bleeding diastasis. Going to past history, there was no history of similar complaints in the past or tingling numbness, no history of type 2 diabetes mellitus, hypothyroidism, systemic hypertension, epilepsy disorder.
So why do you
There
ask
was
for diabetes history? History of diabetes.
Sir, the patient could have had peripheral neuropathy. Sir.
Okay. So what is DISH? DISH, DISH. Okay. What is the Bruns-Garland syndrome?
Sir, radic plexo.
Okay, go and refer. So regarding thyroid, how does it cause weakness? Is it related to weakness somehow?
Sir, because reduced, increased threshold, sir. The,
Hyperthyroidism will cause which electrolyte abnormality?
sir, hypokalemia.
Okay, so that can cause paralysis. Okay, proceed.
There was a history of trauma 1 year back. He sustained the injury to the left shoulder following a two-wheeler accident and suffered abrasions over left shoulder. There were no injuries to head, neck, or loss of consciousness or ENT bleed, following which the patient had taken native treatment and had used arm sling for a month. There was no history of any previous surgeries, hospital admissions, chronic drug intake, or alternative medications intake. No history of similar events in family. Treatment history. Patient was symptomatically treated following trauma in GH. Exact treatment details unknown. There were no procedures were done, and they have taken a scan, and doctors have informed them that there might be improvement with physiotherapy. Outside reports and summary investigations were not available. Moving to the person's history, he consumes mixed diet, normal sleep, reduced appetite, increased frequency of micturition, present voids up to 12 to 13 times a day. He was a reformed alcoholic and smoker, consumed 1 quarter per week for the past 10 years, and 1 packet BD per week for the past 20 years. He is an unmarried male and he denies any sexual contact.
So why did you ask for sexual contact history?
Sir, HIV, because HIV myelopathy can be there, sir.
Okay, what is HIV myelopathy?
Sir, it can cause peripheral neuropathy, sir, and it can
No,
cause.
we are talking about myelopathy.
Sir, vacuolated myelopathy, sir.
Yes, good. Vacuolating myelopathy. What are the two tracks which are involved?
Sir, it will cause initially ataxic, then followed by spastic weakness. So posterior column and spinothalamic tract.
No, so it is similar to a subacute combined degeneration. So it will involve your dorsal column and corticospinal tract. So HIV myelopathy. Okay.
Okay.
Then syphilis is it related somehow to spinal cord?
Sir, it can cause tapes dorsalis, sir.
Yes, good. What tape is dorsalis?
Sir, it involves posterior column. So the patient will have ataxia, then the patient will have impaired proprioception.
Okay.
Reduced reflexes.
Okay, proceed.
So the history is a 54-year-old male who was presented to our OPD with the history of fever for three days, and following a trauma which has happened 7 months back, following which he had a history which was suggestive of spastic quadriparesis, which had improved and now presented with contractions and with involvement of bladder in the form of upper motor neuron type, and the probable structures involved could be corticospinal tract, spinothalamic tract, and bowel bladder involvement. The provisional diagnosis after the initial history is spastic quadriparesis, and the possible differentials could be a post-traumatic cervical injury in a pre-existing degenerative disc disease, or could be intervertebral disc prolapse, or could be a hematoma or spondylolisthesis, or since the patient did not have any history suggestive of posterior column involvement, injury to anterior spinal artery or radicular artery, I would like to keep it as a second DD.
How did you rule out posterior column involvement in this patient from history?
Sir, he didn't tell any pins and needle sensation or paresthesia, sir. He didn't give any history regarding worsening in dark environment.
Okay, what do you call that
And
sign
no
as?
limits. Sir, wash basin.
Wash basin sign. Okay. Proceed.
And patient can have transverse myelitis because it was sudden onset and bladder early, but then other since he is a elderly smoker, that could have been a malignancy that could have caused, but there was no history of any pain previously. So these are my provisional diagnosis. These are the possible DDs.
So what is the central cord syndrome, Kalai?
Sir, in case of presence of any centrally occupying lesions like syrinx or ependymoma, that would be involvement of first initially the patient will have dissociative sensory loss, and the patient will have a sacral sparring, and he will have an early bladder involvement, sir. And, there could be involvement of long tract anterior horn cells. So there could be history suggested like a man in the barrel. They can
Okay,
present,
what is the usual type of cervical injury that leads to the central cord syndrome?
Sir, falling, the hyperextension injuries, falling forward.
What do you call that injury as?
Hyperextension.
What is whiplash injury? Okay, go on study. So, could there be any pre-existing cervical spondylosis in this patient?
So that could have been, sir, but there was no history. Sir, but his age is 50, sir, more than 50, so there could have been, because it was only a trivial trauma, sir, but post-trauma, he developed this much weak, so we can suspect that there is a pre-existing structural disease, sir.
Okay.
Could have been.
Doctor, MS is very unlikely for this patient. Okay, don't put the diagnosis MS in this patient. Okay. Because there is no MS symptom at all for him.
Yes, ma'am. Yes, ma'am.
Typically, a cervical cord pathology looks like okay.
Okay. Yes, ma'am.
Transverse myelitis also will not come for this patient.
Okay.
Because there is no clear-cut demarcation.
Yes.
Okay.
Yes.
And first will be cervical spondylosis. It must be a long-standing cervical spondylotic patient, or there will be OPLL could be there. There will be a ossification of the posterior ligament, and malignancy can be a possible since he's a smoker. Malignancy with metastasis is possible. Even anterior artery history is not fitting into that. So those two diagnoses will not come for this patient.
Okay.
Okay.
Yes.
Yes, Kalai, as ma'am pointed out, one of the mechanisms for compression in cervical spondylosis is ossification of posterior longitudinal ligament. What are the other mechanisms of compression in case of cervical spondylosis other than ossification of posterior longitudinal ligament?
So ligamentum flavum.
Yes, ligamentum flavum hypertrophy. Good. Where? What is an osteophyte?
So it is formation of new bones between the intervertebral.
Okay, what is the usual site of cervical spondylosis?
So usually in the C7.
C7.
C5.
C5 to C6.
C5 to C6.
Okay, pa. Okay. So one more thing, what is clipper? Since it's mentioned in Harrison, we'll just have a small.
It is chronic, chronic lymphoinfiltrative Fontaine very regular changes, sir, which is responsive to steroids.
Yes, so those can also happen in the cervical region. Okay, good.
Yes.
Okay.
Yes, sir.
Hmm.
So moving to examination. After obtaining consent, patient was examined in supine and sitting posture. He was conscious, oriented to time, place, and person. He was a thin-built and malnourished. There was no pallor, icterus, cyanosis.
If there is anemia
clubbing.
plus weakness of limbs, what will you suspect? Or paraparesis or quadriparesis, what will you suspect? Pallor plus quadriparesis causes.
Sir, thalassemia can cause
Yes, good. How thalassemia will cause compressive myelopathy?
extramedullary.
Yes, good. Extramedullary hematopoiesis, so there will be expansion of vertebral body. Yes. Any other reason for anemia?
B12 deficiency.
Yes, good. Subacute combined degeneration because of B12 deficiency.
Sickle cell.
Yes, good. Sickle cell crisis can cause anterior spinal artery infarcts. Yes, good. Proceed.
Yes. Thanks. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. His
If there
height
is
was
generalized
170.
lymphadenopathy in this patient, what would you have suspected?
Sir, it could be lymphoma and
Possible.
then HTLV related.
HIV, not HTLV, HIV, okay.
HIV, TB.
Miliary TB, yeah.
Okay, what is in nails? No, what is Mees lines?
So,
Since it's a court case, no, I'm asking. Mees lines.
Is due to
No, what is that? It is a horizontal white line seen in the nail, no?
yes.
It
It's
is seen in
usually
which
the heavy
toxicity?
metal.
What?
Heavy
In
metal
which
poison.
toxicity?
Arsenic.
Yeah, arsenic. Yeah. Okay. Okay, good. Have you checked the nails of this patient?
His yes, ma'am. There was long nails from it was he was ill kept, but there was no white lines.
Okay.
Yes.
In the neck,
His
what?
height.
In the throat, what you will see? Any court case with the throat, not for this case, but generally I'm asking.
Throat.
Orange tonsils, have you heard of it?
Yes, ma'am.
Just read about it, no? Orange tonsils
Yes.
seen in Tange's disease, no?
Yes, ma'am. Yes.
Okay.
Then his height
So
neck ratio.
why do you check for
Or
height neck ratio, Kalai, in this case?
Sir, in case of any clipple.
To rule out short neck, okay.
Short neck.
Where will you expect short neck?
So in the clipple.
What does clipple feel triad or feels triad?
Short neck and limited low hairline and limited movements of neck.
Okay, when do you call it as a low hairline? It should be below C4 to call it as low hairline. Okay, that can cause high cervical cord lesion. So when do you call it a short neck? What should be the ratio?
Sir, we use Bird's index, sir.
Hmm.
It is less than 1.28 is normal, sir. 12.8, and it is more than 13.4. It's we can call it as short neck.
Okay. Proceed.
Yes. So move to the head-to-toe examination. Right-handedness plus latitude. Patient was in supine position. His bilateral shoulders were adducted, elbow flexed. Wrist contractions were noted. Generalized wastings were present, but prominent wasting was present in lumbricals and lower part of trapezius. On wrist flexion, clawing of hand noted. Bilateral hip adducted with the knee extended. Fixed flexion deformity of lower limb below knee was noted.
So if it was a quadriparesis case, then how will you check for the handedness, Kalai, without asking history? Objectively, how will you check for the dominant hemisphere?
Sir, ask them to.
Patient's power 0/5, quadriparesis. So you should not ask the patient, but you should do a test to find out the dominant hemisphere. What will you do? What is WADA test? Go and study about WADA test. Okay. Can you name few causes of small muscle wasting of hands?
Sir, in case of in thenar case of motor neuron disease, that could be thenar wasting cells.
You stick to this case. Can cervical spondylosis cause small muscle wasting?
Yes, sir. If it involves C8 T1 regions.
What could be the mechanism? Usual site was C5, C6. Then how would it
because
involve
of
C8, T1?
venous congestion.
Yes, good.
And
Venous congestion.
Anterior cell loss in C8 T1.
Yes, yes, good, good. Proceed.
Yes, thanks. Generalized wasting was noted, but prominent wasting of lumbricals and the lower part of trapezium was noted. On wrist flexion, clawing of hand noted. Sorry, I've already told this. There was poor self-hygiene, long nails, he was ill-kempt, and foot stains were noted in the dress. There was no gibbous, spinal deformity. There was no tropic changes of skin or ulcer or skin thickening. No bed sores, no neurocutaneous markers of prominent occiput or kyphoscoliosis. There was no spine tenderness. There was no twitching or fasciculations.
Suppose if you are noticing some involuntary movements in case of quadriparesis or paraparesis, what will you suspect?
If there is any twitching, then at that level, that could be, you can take it as a sign of segmental signs.
Leave fasciculation. I'm asking you about other involuntary movements.
Sir, could it be mass reflex?
So what is mini polymyoclonus? So you can get that in spinal muscular atrophy. So it's a type of lower motor neuron predominant motor neuron disease.
Okay.
Okay, okay. Proceed.
Yes, pulse rate was 117 per minute, regular in rhythm, normal in volume and character, no radial or radiofemoral delay. All peripheral pulses felt equally, no vessel wall thickening. BP was 140 by 70 millimeter of mercury, measured in right arm in supine position. There was no orthostatic hypertension. Respiratory rate was 18 per minute. Thoracoabdominal type. Saturation was 99% in rumor. It was afebrile.
So if there is hypertension, what would you have suspected in this case?
Sir, autonomic dysreflexia.
Yes, which disease will cause that with the weakness of limbs? Which type of quadriparesis or paraparesis is associated with autonomic disturbances predominantly? GBS PA. So GBS is associated with autonomic disturbances. Then, so if there is hypertension plus weakness, what other disease you will suspect? Especially associated with history of abdominal pain and psychotic episodes. Porphyria, acute intermittent porphyria can also cause muscle weakness and autonomic disturbances. If there is chest pain with high BP and muscle weakness of limbs, what will you suspect? Dissection, aortic dissection. So they can involve dissection of artery supplying the spine. So can you tell me about the artery of Adam-Kiewicz?
Sir, it is a radicular artery, sir. Usually arises below C4 segment, sir, and it has a watershed. It supplies majority of anterior spinal artery.
It reinforces anterior spinal artery in the lower thoracic spine. Okay, proceed.
Move to serious examination, higher mental examination. Patient was conscious, oriented to time, place, and person. Memory was intact. Both immediate, recent, remote memory were intact. Speech and language was normal. Emergency was 30 by 30. Wound and effect was normal.
If you had dementia with the quadriparesis, what will you suspect?
Sir, HIV can.
Yes, good.
Syphilis, general.
Okay, HIV. Okay, proceed.
Cranial nerves, all cranial nerves were cranial nerve examinations. There was no significant changes except for wasting of trapezium. So lower trapezium, there was significant wasting. Other than that, no other abnormalities.
For this patient, which cranial nerve will be most importantly seeing?
This patient, lower cranial nerves.
Lower cranial nerves. Okay. What we lower cranial nerves, if it is there, what will you diagnose there? Like 9, 10, 11, 12, you're telling, no?
Can suspect any posterior CV junction anomalies. They can have syringomyelia, syringobulbia can be there. Then if there is a presence of bilateral element type of facial nerve, we can, that would be DD for like GBS could have been a DD.
Okay. Another cranial nerve? You have examined, no?
Optic neuritis, optic atrophies.
Atrophy. Okay. So what will be your differential diagnosis for optic atrophy?
In B12 deficiency, that would be optic atrophy. And then,
B12 deficiency are very rare actually. I've never seen a case.
Even in NMO, that would be, and we should see any choroid tubercles, because since he had
choroid tubercles, you're right. So if it is choroid tubercles, what is it is called? Miliary TB, no? In miliary TB only you'll see choroid tubercles. Okay. Okay. Well, what is like? Where will you see cherry red spot?
In case of infect.
Okay, you read about it. You message me.
Yes.
Okay. You see fifth now, no? So jaw, jaw jerk, no? That is the answer. What the question? Okay. So what jaw jerk it is normal, no?
Yes.
If it is exaggerated jaw jerk, then where will be your localizing sign?
Jaw jerk is exaggerated. Then it be in,
what?
It will be in pons.
Okay. Pond or above pons. Okay. Bilateral.
Yes.
Okay, bilateral. It is a bilateral representation, jaw jerk.
Yes.
Okay.
Yes.
So where like what it is called? That palsy is called what palsy is that? Pseudobulbar?
Pseudobulbar palsy.
What are the other features of pseudobulbar palsy?
That would be dysarthria, dysphonia, and the emotional lability.
Okay. So for this case, you can get a pseudobulbar palsy. What will be the diagnosis?
MS, MND.
MS illa. MND da. ALS, PLS. Okay, ALS. Okay.
Okay. Yes.
Okay. So fifth nerve is very. How will you examine fifth nerve? Jaw jerk, sorry. I mean, how did you examine? Can you just explain?
Ask the patient to keep his mouth half open.
Not half, lightly open. Slightly open.
Slightly,
not
okay,
fully
slightly
half
open.
also not accepted. Slightly open. Okay.
Okay. Then keep
put your thumb over the chin.
Thumb over the chin. Then we'll strike with the
knee hammer.
Gentle strike with the knee hammer. Then we'll look for closure of.
Okay. Slight and no response is normal. Okay.
Okay.
Exaggerated response is abnormal. Okay. Slight response, you don't tell it as abnormal jaw jerk. Okay.
Okay.
That you.
Yes.
Okay. Okay, you can go ahead, please.
Yes. So moving to bulk, he had generalized wasting and moving to tone. Both upper limb and lower limb, he had a class type of vegetative.
Can you define tone?
Tone, it is the resistance given by the muscle for passive stretching.
Yeah, resistance given to a resting muscle for the passive stretch.
Yes.
So how will you, what is can you explain more about spasticity? What it is like? In which muscle, in which group of muscles you'll see the?
Spasticity is mainly because of involvement of corticospinal tract. So it will be mostly in the intrinsic muscles.
No, spasticity. No, you have written clasp knife. No, without the spasticity, only clasp knife will be there. Initially, there will be spasticity, no, and then only the clasp knife will be there, no. No, I want to know why you have mentioned only the clasp knife. I want to know. I didn't. That's why I'm asking.
I didn't include both.
You have to put spasticity also, no?
Yes, the patient
Spastic.
had.
Yes. Tell me.
Patient had shakiness whenever we, even with a slight movement, he had severe
That the
shakiness of hand.
jitterness and shakiness was
Yes,
there.
ma'am. Yes, ma'am. Yes, ma'am.
That
But
could be
when we
because of
examined, he had
weakness.
that
Yeah.
giveaway. Yes, ma'am.
No, giving away is by extending the arm only, no, you'll be having. But for spasticity, no, first you have to flex the arm, no, to see.
Yes, ma'am.
Can you define spasticity?
It's a velocity dependent.
Very good. What does that mean?
When we give when the velocity
When
increases,
the resistance increases,
there'll be
so
increase in the
linearly the velocity also will increase. Like
it's due to
yeah, the velocity of the stretch. It is linearly related to the velocity of the stretch.
yes, ma'am.
The resistance will increase, keep on increasing. Class knife is it is then the resistance will go away.
Yes, ma'am.
Suddenly the
Giveaway.
resistance will go away. That's why I was surprised why you were doing only class knife.
Yes, ma'am. Sorry.
So in which group of muscles you see spasticity?
More in the
More in the anti-gravity
gravity.
muscles. So in arms it is the flexors and the in the leg it is extensors. So flexion and extension you have to do both. Okay.
Yes.
Okay. Have you checked the lower limb extensors also? No. In even lower limb extensor you felt the clasp knife.
Actually, he had that.
It was giving away. The resistance went away suddenly.
He actually had that jitteriness from
flexion.
He had that. So
Doctor, don't tell jitterness. Okay, jitterness totally localizing to some other place, not in the tone or the muscle or human.
okay.
So we are just talking only about spasticity. So you change this thing. Don't only write clasp knife because the exam will call both of you. Why you're writing clasp? You have to write spasticity with clasp knife.
Okay.
So you don't mention clasp knife itself. Just to mention rigid. All the limbs were rigid.
Okay.
Like that. Oh, okay.
Okay. Sure.
Okay. There was no atrophy for this patient. Yeah, only the small muscle hand only was having atrophy, right?
Actually, he had generalized wasting, but the prominence was in lumbricals and shoulder trapezium.
Okay, then you already localized that. Okay, okay. Okay, you can move on.
Yes. Moving to power, left shoulder abduction was 3/5. Others all had 4-5. That he had an injury in the left shoulder, so probably that could have caused 3/5. So he had.
So is it symmetrical or asymmetrical?
So, except for that, it is symmetrical.
Okay. What is the usual pattern of progression of weakness in a compressive myelopathy case? Usual pattern of progression, especially in a high cord lesion or a foramen magnum.
Sir, it will be there could be U phenomenon, sir.
What do you call that as?
Sir, Ellsberg.
Yes. So clockwise progression.
Yes, sir.
Okay. What is Ellsberg?
Would be, sir,
Yes. What is Ellsberg syndrome?
So that is due to HSV2, sir. It can cause cauda. Recurrent cauda.
So radiculitis.
Radiculitis during epidemics.
Reactivation of genital herpes. Okay. Okay.
Yes. So his wrist flexion and extension was 4/5 and 3/5. His hand grip was 50%. In lower limb, hip flexion was 4/5. Hip extension was bilaterally 4/5. Hip adduction bilaterally it was 4/5. Hip abduction was 4/5. Internal and external rotation was 4/5. His knee flexion was 4/5. Knee extension was 4/5. Ankle dorsiflexion, plantar flexion was 4/5. Neck flexion and extension 4/5. Truncal, there was truncal weakness. He was not able to roll over. That I couldn't assess properly, sir, because Because, is it because of spasticity or weakness? I'm not so sure, sir. And a single breath count was 18 seconds. Moving to superficial reflexes, corneal conjunctival reflexes were present. Abdominal reflexes was absent. Bulbocavernous and anal and cremastic reflexes, I couldn't do, sir. It was not.
Can you name few conditions where even in upper motor neuron lesion, abdominal reflexes will be preserved? Causes of
Sir.
preserved abdominal reflexes in a human lesion.
Sir, there is a lesion in umbilicus, that could be Beavis.
No. I asked you the preserved abdominal reflexes in case of usually in human you will have abolition of abdominal
Yes, sir.
reflexes. So if it is preserved, what you will suspect? So you will suspect motor neuron disease.
Okay, sir.
And also in cerebral diplegia or infantile hemiplegia also it will be preserved.
Okay.
Okay.
Bilateral plantar was extensor. Deep tendon reflex, biceps, triceps, brachioradialis, pectoralis reflex, clavicle, pronator were all 3+. Wrist flexion reflex was 3+. Wrist extension could not be assessed due to contraction.
What is the root value of biceps?
So C7.
It is exaggerated. So where are you going to put the lesion?
Sir, above C7.
Biceps C7.
Sir, the biceps is C5. Triceps
Okay.
is C7.
Okay.
So it's above C5. Sir. Since
Okay.
biceps is.
Okay.
Yes. Knee suprapatellar and infrapatellar reflexes are exaggerated, and I couldn't elicit hamstring or puboadductor reflex or postoperiapstal reflex or scapulofemoral rectal reflex. So my findings, there were spread of reflexes.
What about the ankle reflex, sir? Ankle, is it present or absent?
It was exaggerated.
Okay. So
Okay. Ma'am, you can ask, ma'am. Hello.
Yes, ma'am.
No, you can't. No problem. No, can't.
Okay. Akala, ma'am mentioned about ankle reflex. If there is extensor plantar and absent ankle reflex, then what will you suspect?
Sir, there could be tapes, dorsalis, could be Frederick's.
Okay. First GD should be subacute combined degeneration. Extensor plantar with absent deep tendon reflex. Okay. Proceed.
What are the other causes, sir?
Yes.
Only. Frederick's ataxia.
Tapes, dorsalis.
Yeah, tapes dorsalis. Frederick's ataxia.
MND.
Okay. Syringomyelia, there'll be in syringomyelia also. There'll be brisk knee reflex, depressed ankle, decreased or absent ankle jerks, and extensor plantar response will be there. So as I was telling, first you have to tell only subacute combined degeneration, okay?
Okay.
And then all these other things, Frederick's ataxia,
yes,
your copper deficiency, HTLV, copper deficiency, you have to definitely tell. Spinal dural AV fistula, all those things. Okay.
Yes.
At least 5 causes you remember. This 5 definitely will ask this question in an exam. They'll definitely ask. Brisk knee jerks with depressed ankle jerks. SCAD, ALS, your case, no, the same case, spinal spondylosis also sometimes it will be absent. Syringomyelia, Frederick's ataxia, copper deficiency, HTLV, and spinal dural AV fistula. Okay, you remember this one, okay?
Yes.
Okay.
Yes. So in my examination, there was a spread of reflex, and there was inverted supinator reflex was noted. There was no cross.
What is inverted supinator reflex?
Sir, on eliciting, there will be flexion. flexion of elbow, sir, instead of supination.
Flexion of elbow.
It's flexion of fingers.
Fingers. Okay. Okay.
There was no cross reflex or clonus I couldn't elicit, sir, in ankle and because of contractures, and Weaver sign was negative, and Wattenberg sign was present. Hoffman's ankle knee clonus I couldn't elicit. There was presence of.
What is the frequency of the hertz in the clonus? How much per second hertz? Clonus means it is element or human?
Huh?
Clonus means it is whether localizing to human or element. Human. Hertz will be around 5 to 7 hertz. Huh?
Okay.
It is given in John Patton book. You just read that once. Huh?
Yes,
inverted reflex, what did you tell? Absent of biceps and presence of triceps, no?
Presence of finger flexion.
If you elicit the biceps, and there will be only triceps and finger flexion response will be there.
Yes.
Okay.
Yes.
Okay. That is where is the localizing lesion for that? Inverted reflex.
It's above. It denotes that there is a increased reflexogenic.
No. I'm just localizing like radical C5, C6. Okay.
Yes.
Inverted is inverted C5, C6 for the biceps. Okay.
Yes.
Okay.
And I could notice jerkiness on eliciting biceps reflex. Moving to gait, patient could not be able to stand without support, needs crutches, and one person for support to walk. And he took short steps with slow and jerky movements, with the drying of toes. There was no scissoring of legs noted. So it is a spastic type of gait.
Can you tell me some types of gait?
That would be magnetic gait.
Okay.
Parkinson's gait, antalgic gait, cautious gait.
Cautious gait. அந்த மாதிரி ஒரு gait இல்லையே. First is cerebral gait. Always start with cerebral gait, okay?
Okay.
Sensory ataxic gait, hemiplegic gait, Festinian gait, waddling gait, dystonic gait, okay, hemiplegic gait, or steppage gait, or frontal lobe disorder gait, okay?
Yes.
First you start with cerebral gait.
Yes.
So this patient you're telling, how are you telling it? You're not telling it scissoring இல்லைன்னு சொல்றீங்க, but spastic gait எப்படி சொல்றீங்க? Short step, slow எல்லாம் வந்து பார்க்கின்சன் மாதிரி சொல்றீங்களே.
So we actually walked out.
You have a video of this patient? No, illa? Always better to have a gait video so that we can assess.
Yes.
White base gait illa normal base gait adella you didn't write, no?
Yes. You
So there must be a mild scissoring irundukume, just or illaya you didn't have.
Actually he was very slow. He is only taking very few steps.
Because of the fever, he was not able to walk. Okay.
Not just that, he's had full contractions, so he's only walking very slowly. He's taking very small steps to move. Like for a 10 meter, he almost took for 20 minutes. Very slow. He had full jerkiness. For even a slight movement, he has jerks.
Okay. For spastic gait, no. Okay. How will the patient walk?
They'll have a circumflexion. That could be
correct. You're right. Swinging, circumflecting gait, or stiff patient. Stiff, like the legs and the arms will be the arms will not towards the body.
Yes.
Okay.
And the toe tipping.
Yeah, okay, toe tipping. But the foot will be dragging.
Yes.
Okay, this is a typical
Spastic.
spastic gait. Where all you see spastic gait?
Um,
Except for cervical spondylosis.
It can be in cortical lesions. It could be in multiple sclerosis. Could
Okay.
be in
Okay. Multiple sclerosis. Stroke patients, no? One page. Stroke, spinal cord injury, cerebral palsy. Okay. Okay. Okay.
this one.
Okay. You can move on to the next one.
Moving to the sensory system, root touch pain temperature was intact up to the level of T10. Fine touch proprioception, position sense, he was able to tell, but vibration sense he couldn't feel below dorsal vertebra. And, secondary sensations, tactile localization, 2-point discrimination, graphesthesia, stereognosis, is able to tell.
So, Kalai, can you tell me some causes of card compression at multiple levels?
Sir, intervertebral disc prolapse, sir.
Okay.
High velocity injuries, metastasis.
Metastasis, okay. Neurofibroma,
It's a neurofibroma.
AV malformations. Okay, proceed.
Cerebellum examination, there was no nystagmus.
No, sorry. Can you go to the previous slide? Can you just tell me the just localizing tracks? What was reading?
Yes, ma'am.
Fine touch proprioception is which tract? Position sensor. No?
Yes, ma'am. It is posterior column, the middle meniscus.
Okay.
Then
What about root touch pain temperature?
That is spinothalamic tract.
Spinothalamic tract. Okay. Okay.
Yes, ma'am. Cerebellum examination, there was no nystagmus, no saccades in both eyes. Other cerebral examination was not assessed because he had a serious spasticity. Moving to autonomic nervous system, there was no postural hypotension. There was no abnormal sweating. There was resting tachycardia. His heart rate was around 117.
So if his power is 0/5, how will you check for autonomic function? What are the methods to assess autonomic function?
Sir, presence of mass reflex can cause.
No, I'm asking you tests for autonomic function. If you're unable to do postural hypotension,
Piloerection for pain.
can Valsalva be done to assess your autonomic nervous system? Valsalva maneuver. Go and study how Valsalva maneuver is used to assess your autonomic function. What is Q-SART? So go and study about tests for autonomic function. Q-SART. Study about Q-SART. What is head-up tilt test? These are the tests used to check for your autonomic nervous system. Okay. Which we already discussed about the diseases associated with autonomic nervous system and weakness of limbs. Okay, proceed.
So my final diagnosis is
Did you check for local examination of spine that you have not mentioned? Local examination of spine and cranium.
I mentioned in the literature there was no because of spinal tenderness or deformities.
Okay.
So kyphoscoliosis.
What are the other local things you will see in spine? Okay, if you are hearing spinal bruit, what will you suspect?
Sir, AV malformation.
Yes, good, AV malformation. Okay.
My neurological diagnosis is spastic quadriparesis with contractions with loss of vibration sense and spinal sensations below T10 and and bladder. My anatomical localization, I want to keep it above C5, probably at C4 because of trapezius wasting, especially lower trapezius wasting. Pathological diagnosis, I want to attribute to compressive myelopathy. Probably the plane of compression is extra medullary, extra dural compression, secondary to trauma.
Okay. Can you classify compressive myelopathy?
Could be extramedullary and intramedullary. Could be in extramedullary.
No.
Could
First
be
it is extradural and intradural for compressive. Compressive myelopathy. First is extradural, அப்புறம் intradural classify பண்றோம். அப்புறம் intradural தான் extramedullary or
Yes, ma'am.
intramedullary. Okay.
Yes, ma'am.
So you're telling this as an extramedullary, extradural.
Extradural.
Okay. Okay. No problem. Secondary to trauma. C4 compressor. Okay, good. You presented well. Can you tell me some causes of extradural compression except apart from this?
Spondylolisthesis.
Yeah, degenerative spine diseases. Okay. அதுல எல்லாம் வந்துரும் உங்களுக்கு. Okay.
Metastasis.
Metastasis. But the tumor, primary and secondary primary and secondary. Okay.
Secondary could be either from breast, prostate, or it could be from retroperitoneal. That can cause radiculopathy type of pains because it mostly localizes at the intervertebral foramen.
Okay, important infective cause, spot spine இருக்குல்ல?
Spot spine, yes.
First diagnosis always in our country. Traumatic spine injury, spot spine, and your cervical spondylosis. Okay.
Yes.
Intradural compressionல வந்து extramedullary and intramedullary differentiate பண்ணுவாங்க இல்லையா? அதுல ஏதாச்சும் காசஸ் தெரியுமா உங்களுக்கு? Intramedullary is very easy இல்ல? Inside the cord என்ன இருக்கும்? என்னவா இருக்கும்? Inside the cord என்னவா இருக்கும்?
Said it could be epidural.
Since it is high cord la நீங்க ஈஸியா சொல்லலாம். Syringomyelia.
Syringomyelia, then ependymoma. Ependymoma can be there.
Yeah, ependymoma, glioma, all the gliomas, astrocytomas, ependymoma, அதெல்லாம் வந்து intramedullary. ஓகேங்களா? Okay, good. Extramedullary, what will be there? Meninges involve ஆகும் இல்லையா? Extramedullary na. Meningiomas. அப்புறம் நம்ம TB, arachnoiditis வரும். Tuberculosis, arachnoiditis, it will be there. Okay.
Yes.
So now you'll remember, like compressive myelopathy, it is extradural or intradural.
Yes.
In intradural, it is intramedullary and extramedullary. First, intramedullary, if you remember, now you will not forget the causes. That's why I always go with intramedullary first, and then you'll go for extramedullary.
Yes.
Okay. So non-compressive myelopathy, the causes? Can you tell me some non-compressive myelopathy causes?
The vascular.
Vascular, okay. Vascular, okay.
Then that could be
இல்ல நீங்க டிஃபரன்ஷியல் டயக்னோசிஸ் கொடுத்திருந்தீங்க இல்லையா அதுல டிரான்ஸ்வர்ஸ் மைலைட்டிஸ் னு சொல்லிட்டு அதுக்காக கேக்குறேன்.
Yes, it could be inflammatory. Inflammatory could be neuromyelitis, multiple sclerosis.
Very good.
Could be transverse myelitis.
Transverse myelitis.
Infective myelitis.
Very good.
Post-infective myelitis, vaccine associated. Nutritional deficiency like low vitamin B12 deficiency, folate deficiency, or copper deficiency, or zinc toxicity.
Okay.
Nitric oxide.
Radiation myelopathy also very common because many malignancy patients we see radiation will be given 2-3 years before, but the patient will develop myelopathy later also.
Yes.
Even radiation encephalopathy, like that radiation myelopathy and all, patient will develop later. Even after 3 years, 4 years, they will develop. Even encephalopathy, they will develop later. So always the radiation is very important because lots of malignancy are more common nowadays in this way.
Yes.
Okay. Toxic la vandu laterism. Yes. Paraneoplastic you have to think. It's a very rare cause, but paraneoplastic also we have to think. Non-compressive.
Yes.
Okay. And degenerative. Okay.
Yes.
Degenerative causes. Okay. So நீங்க கேளுங்க சார்.
Okay. Can you tell me a few causes of high cervical cord lesion?
Sir, it could be Arnold-Chiari malformation. Sir.
Yes, good. What is Arnold-Chiari malformation?
Sir, that could be there is herniation of tonsils. That is type 1, sir, and herniation of tonsil with meningocele will be type 2, sir. 3 will be with meningomyelocele, sir. 4 there is type 4 there is posterior fossa aplasia.
Okay. Other causes other than Arnold-Chiari malformation, other causes.
Dandy Walker. Dandy Walker, there is obstruction of the, there will be a dilatation of the.
Any other
ventricle.
cause?
So then Kleppel syndrome, sir.
Okay.
Syrinx can cause that.
Syringobulbia. Okay.
Syringobulbia.
Extension of syringobulbia. Seri vera.
So meningioma can also cause CV junction.
What is platybasia?
That is a flatness of the occiput.
Seen in which disease? Paget's disease. Vera. Rheumatoid arthritis, you should never forget.
Yeah, RA is very important.
Yes.
Okay, okay. Will ankylosing spondylitis affect your C-spine? No, it usually doesn't affect your C-spine. Okay. So what are the clinical features which will favor high cervical cord lesion? Now we discussed the causes. Can you tell me a few clinical features?
So in high cord lesion, there could be downbeating nystagmus.
Yes, good.
Involvement of phrenic nerves.
Possible. 3, 4,
Then
5.
suboccipital pain will be there, sir.
Yes. What is mirror image movement?
Sir?
Mirror image movement. Where will you have mirror image movements? In Arnold CRE, you can have mirror image movements as well. Okay, pa. So can you name a few other causes of spastic quadriparesis?
Sir, primary ALS can cause spastic quadriparesis. Then HTLV will cause tropical paraparesis.
Tropical spastic quadriparesis. Okay.
Paraparesis. Then lepthyrism can cause that. Then hereditary spastic paraparesis can cause that.
Hereditary spastic HSP. Okay, okay. So these are the causes of spastic quadriparesis.
Then bilateral meningioma.
Meningioma.
Parasagittal meningioma.
Okay. So have you heard about we discussed about pseudobulbar palsy, MND. Which is the one factor which is strongly against MND in this case?
So there was George.
MND can have spastic quadriparesis. Sensory tract involvement.
Okay, sir. Only.
Okay. And what is ultimum variance in MND?
So first initially it will start as focal disease, then asymmetric. Certain
structures will never be involved in MND. So bladder will never be involved.
Okay, sir.
Okay. So involvement of sensory system, bladder involvement. So all goes against MND.
Motor.
Okay, pa. So what are the factors favoring compressive myelopathy in this case?
Trauma, sir. Then,
trauma history. Okay.
There is a bilateral involvement, sir. Usually in extramedullary, that can cause. There was
usually how will you differentiate compressive and non-compressive?
Sir, say exact level of lesion will be there, sir, compression, and there will be presence of pain, sir. Then there will be other involvements, sir, like non-compressive. It can involve optic.
So this will be the first question in exam. When you present it as compressive myelopathy, they will ask you how will you differentiate compressive from non-compressive. So okay, be thorough with those questions. So you have to answer rapidly to those questions.
Yes, sir.
Okay, okay. Ma'am, do you want to... okay, okay.
Yes, sir.
Okay.
When will there be a sequential involvement of drugs, and when will there be a simultaneous involvement of tracks when it comes to compressive and non-compressive?
So simultaneous involvement will be in non-compressive.
Most likely, non-compressive, there will be simultaneous involvement of tracks.
Yes, and early bladder will be.
Yeah, bladder can be involved early, yes. But in compressive, since it is usually it progresses slowly. Unlike this case, usually the patient will present slowly, so there will be a sequential involvement of tracks. Okay?
Yes, sir. Yes, sir.
So, what are the spinal cord symptoms? Since your spinal cord is your main case, what are the spinal cord syndromes that you can think of when a patient presents?
So that would be pan cord syndrome, sir.
Okay,
Where,
like this case, right? The case we are
yes.
dealing right now, it's a pan cord syndrome.
So,
Complete cord syndrome, okay.
Yes, that could be Brown Sequard syndrome, sir. Hemi section. Then that could be involvement of posterior column alone, sir. Like subacute combined degeneration. Then that could be involvement of infarction of anterior spinal artery, sir. So anterior cord syndrome, sir.
Okay.
Then it could be central cord syndrome, sir.
Okay. And that can be pure anterior horn cell involvement also.
Pure anterior.
Yes. Okay.
Since this patient only presented for URI, sir, so we
can you tell about the Brown Sequard? What are the tracks involved in Brown Sequard?
In Brown Sequard, there will be ipsilateral loss of corticospinal tract weakness and posterior column sensation. There will be contralateral loss of pain and temperature because the spinothalamic tract will cross at the cord level 2 to 3 segments above the cord, spinal cord level itself. It will cross.
Okay. Okay. Good.
Shall we end up, ma'am, if there are no further discussions?
Yes, sir. Sure. Yes.
Okay. Sir, do you want to add any questions, sir? Vishnu, sir?
No, sir.
Okay. Thank you, sir. Thank you.
Really, thank you, Dr. Harishwar and Vishnu. I'm just there. I didn't discuss about the case, so that's all. And Preeta also for wonderful discussion. I think made the discussion more interesting and more exam-oriented pattern of questions, especially Harishwar was asking from the beginning. And both the neurologists also asked more of practical questions. Really thank all the three faculties for this wonderful discussion.
Thank you, sir.
Thank you, sir. Thank you, sir.
Yeah, really appreciate Harishwar also for so much interest in neurology, Harishwar. Yeah, you understand the questions which are putting forward, and I think you have more classes during the regular classes also for the PGs to get more what we call trained in the neurology part. They need more training. I would say more training in this part. Okay, I really appreciate for at least to some extent prepared well for this presentation. It should be going more as Harish were mentioning about the flow of presentation.
Yes.
And answer should be slightly more, especially common questions anticipated. If you're able to answer in a flow manner, that makes a good impression of the examiner that you're a bit familiar with. If you're giving a blank look and giving an answer, which is correct answer, which may be correct answer, but if you take such a fraction of second or a bit of late for answering the question, it sounds is bit of you're not prepared for the question, which is common question. Understand, Kalaya?
Yes.
Go back and start thinking about the common questions anticipated. You create your own questions which can be asked by the examiner and prepare the answer for those questions also. That makes your attending to the exam will be much better way. Okay. Yeah. And thank you everyone of you and good night to all of you. Thank you.
Thank you, sir. Thank you. Thank you.
Thank you, sir. Thank you, sir.